Speaker this afternoon is Dr. Michael Gruntfest. Michael is a PharmD who's one of our T32 fellows here at Indiana University, working with Suresne Desta on a project about Efavirenz.
Hi everyone. As Sarah mentioned, my name is Michael Gruntfest. I'm from PharmD and currently a T32 postdoctoral fellow at the Division of Clinical Pharmacology. Today I'm presenting my research titled Efavirenz enhances the stereoselective metabolism of methadone in healthy participants. So for some background, Efavirenz is a non-nucleoside reverse transcriptase inhibitor used in the treatment of HIV. As I'm sure some of us are aware, as many documented clinically significant drug-drug interactions. Methadone, on the other hand, is an opioid analgesic used in the treatment of opioid use disorder and chronic pain. It is delivered racemically, pictured over to the right, with S-methadone being on the left and R-methadone being on the right. Efavirenz and methadone can be co-administered in HIV patients that are managing opioid use disorder or chronic pain. So taking a look at the methadone metabolic pathway, current literature supports that methadone is actually primarily metabolized by CYP2B6 with some smaller contributions from CYP3A4, 2D6, and 2C19. And is metabolized into its primary metabolite S and R EDDP. The enantiomers of methadone are differentially metabolized with CYP2B6 showing a slight preference for S, CYP2C19 showing a preference for R, and 3A4 showing no preference between either of the isomers. A multiple dose of Efavirenz or steady-state Efavirenz induces CYP enzyme via activation of nuclear receptors CAR and PXR. So the hypothesis we have going into this project is that Efavirenz induces the metabolism of S-methadone to a greater extent than R-methadone. I want to break down this hypothesis into two major aims. Aim one was to characterize the impact of Efavirenz on the enantiomers of methadone and EDDP, and the rest of the presentation is focusing on aim one as there was not enough time to look at aim two. Aim 2, on the other hand, is to compare the extent of induction based on the number of functional CYP2B6 alleles. So we want to see if different metabolizer statuses had were induced differently. Taking a look at their study design, all subjects were screened and genotyped, divided into normal, intermediate, and poor metabolizers. And then in the phase 1 of the study, subjects came into the clinic and were provided a single dose of methadone 10 milligrams. They then provided samples for 72 hours for 16 samples total. Then we provided enough Efavirenz to reach steady state, and that was our phase 2. So they were taking Efavirenz 600 milligrams daily for 16 days. Then subjects were invited to come back for phase 3, where they were provided their final dose of Efavirenz co-administered with methadone 10 milligrams. We then repeated the same sampling over 72 hours, with 16 samples provided in each phase. As for the methods, the stereoisomers of methadone and EDDP were quantified using ultra-high performance liquid chromatography and mass spectroscopy. I'm going to leave it there. Pharmacokinetic parameters were analyzed using Phoenix with Nonlin, and the statistical analysis was completed through GraphPad Prism. So throughout the process, so far we have screened a total of 48 subjects. 8 were excluded due to not meeting our inclusion criteria, abnormal labs, high BMI, or a baseline high QT interval. We had 34 subjects complete phase 1. 5 subjects that were included withdrew before beginning phase 1. We have 1 subject currently enrolled but has not yet completed the phase 1, and 1 subject withdrew without completing phase 1. So they only provided about 8 hours of PK data. So moving on, we had 26 subjects complete phase 2. We had a total of 8 subjects withdraw from the study either after phase 1 or during phase 2. And continuing that on, we had 26 subjects total who completed all 3 phases. Analysis of the PK parameters and concentration versus time curves included subjects that completed both phase 1 and phase 3, but other calculations, including percent change, only include subjects that completed all 3 phases. So let's take a look at the results. Here we have my concentration versus time profiles. The red line is phase 1 or the PK data without Efavirenz, and the blue line is during phase 3 or with Efavirenz. So we would expect to see some kind of induction effect. And I believe that there is some evidence of induction here, as we can see that the blue lines in the metabolites are higher, showing that there was a larger concentration of the metabolites with Efavirenz. But both R and S did show induction. So looking at this further, I decided to focus on the pharmacokinetic parameters of Cmax, AUC 0 to infinity, and clearance over F. Above are the calculated values and the percent change, corresponding percent changes underneath. The blue bars are representing S-methadone, and the red bars are representing R-methadone in this figure. There was a statistically significant reduction in AUC 0 to infinity for both R and S, and this is pretty consistent with a corresponding increase in clearance for those analytes. Looking at the percent change, across the board, the S-methadone, the S enantiomer, had a larger percent change compared to the R enantiomer, and this is consistent across all the pharmacokinetic parameters. My final figure is looking at the parent over metabolite ratio. So this includes an increase of concentration in the metabolites with a decrease in concentration of the parent. Again, the red is R and the blue is S. And we can see with these ratios, both R and S enantiomer ratios experienced a reduction in both Cmax and AUC 0 to 12. The S enantiomer ratio experienced a larger percent change compared to the R enantiomer ratio. So for our conclusions, Efavirenz significantly increased the metabolism of both R and S methadone. The extent of induction is greater for S methadone compared to R methadone. These findings support that patients taking both Efavirenz and methadone may experience a reduced efficacy and reduced toxicity. Some limitations: we currently have 34 subjects that provided data and only 26 subjects that completed the entire study. Of the subjects that have completed the study, we only have 2 poor metabolizers. This makes the allele comparison a little difficult. And some future directions, we are still ongoing with the genotype-based analysis, and we are still actively recruiting. And I just want to acknowledge my mentorship committee and members from Desta's lab. Thank you.